So now you've had a good amount of time to explore mobility skills and see what they look like in lab. So you can think about the fact that we're going to be assessing how they're able to move in the bed, roll, come to sit, coming up to stand if that's possible, and any transfers. In the very beginning phase, we may be using a mechanical lift to move them or using a sliding board for beginning instruction in these techniques. And over time, we're moving towards the patient doing as much of that as possible. Again, a lot of that acute phase may be building up their increased time in tolerating upright. It might be increasing range of motion to where we're going to need it for the mobility, as well as building strength around certain joints. In the more chronic phase, we're really trying to look at the skills that they're able to do and see if we can add anything to their technique or teach them some problem solving or using adaptive equipment to help them be as functional as possible in their environment. Okay? We might be taking time to go back and build up any musculature that they need to be able to do when they've identified possibly a new skill that they want to accomplish. So for instance, some of the patients that we watched weren't able to do some of the skills independently when they went home, but they may come back or seek outpatient for further advancement of those skills. Or maybe they've identified a new skill that they want to learn, such as getting up from the floor, if that's possible. Or maybe they weren't interested in standing or doing ambulation when they left the hospital, and now they might want to do that. Okay, so just like we would do for any other evaluation, we're examining to report what level they're at for each of those skills. We're also thinking that in the acute phase, we may need to watch out for any comorbidities and secondary impairments that they might have. So thinking about this mobility training especially is important. That technique for a patient with a cervical injury, we might need to be working on just seated scoots prior to lateral transfers. And again, sit to and from stand and a stand turn pivot if that's appropriate. But in any of these positions, we have to stop and work on balance in each of those new positions, and if they're having to do something like manage their lower extremities. These are the basic principles on the right that I think if you read through, they should all make sense to things that we have learned. I'm gonna just kind of highlight that again, we might be modifying that task in the very beginning to make it easier to allow for them to build up confidence and capacity, maybe build up range of motion, maybe build up strength in certain joints. And there are some techniques that we might use to do that. In addition, we're going to stop at the place in the task where they're having difficulty and really work in that range or building up the strength in that area. Now, once we have maximized function, or if the patient's going home and they need to have as much independence as possible, even if they do have potential to get more function, we may need to be assisting them in use of adaptive equipment to do things. So here's a few examples that we've briefly talked about, but these are some nice photos of a hand ladder, which can be used in the wheelchair or long sit to work on dressing. And then here's the idea of using a similar thing, but it loops the leg so that the patient can, if they're having difficulty with lower extremity management, they might be able to use that leg loop to assist that. The ADL equipment here is some various things that might be able to be put either in a cuff if the patient is unable to hold them, or using a tenodesis grasp, that you have things that can help you do buttons and maybe zippers. This one, it looks like it's for a zipper. So while I don't expect you to really know all this stuff, I would like you to have an understanding that it exists and which patients might benefit from their use. I'd like you to stop the video now and watch this person, because I really do think this gives a nice overall picture to dressing and those ADLs that the person will be required to do. How much energy it takes and how much energy it takes to set up the tasks. In each position and every task that we're teaching them, balance is going to be paramount. We're going to be thinking about that from both long sitting and short sitting positions, as well as standing if that's an appropriate activity for the patient. We can think about that from an examination reference, and things that might be appropriate could be the Berg Balance Scale, a DGI. You can also use just basic things like how long the patient can maintain sitting in long or short with upper extremity support or without upper extremity support. But this modified functional reach test makes a nice option for sitting balance measurements. As we move on, some patients might be appropriate for ambulation. So how are we going to look at and assess that? It's going to be a little different than our typical. Some of the things might seem very similar. We're going to look at how far they can go, how much assistance they need, what devices they're going to use, the orthosis, and the quality. So depending on the patient's functional level, we could do a 6-minute walk test or a 10-meter walk test. DGI, FGA, you're all very familiar with those if the patient is high enough level and they're appropriate. But in many instances, we're moving them through walking in a very systematic way. Okay, so this WSCI, the walking index for spinal cord injury, makes a really nice marker for how they're doing and how you're progressing. I think a lot of it is very self-explanatory. You're determining which device that they're using, their braces. This is just to document what types of braces here and the amount of assist. Down here, we're going to actually get a level, but I'd like you to look at this last column because we are concerned about how comfortable that patient feels they are in that stage. You may think that the patient is supervision or even ready to be independent, but if they're not feeling comfortable, then they're going to probably want to have an assistant or have somebody walking with them for supervision. Okay, so I really love that they add this patient comfort level over here, but you're really, when you're looking and comparing levels and showing progress, you're going to find the WSCI level here. So whether or not you're in parallel bars, using braces, with however many number of assistants, and then the distance that they're able to go. So that just makes a really nice marker for you on their walking ability. We can start looking at ambulation potential with patients with mid to lower thoracic injuries. There's a lot of research that's going into trying to predict which patients will benefit from ambulation and locomotor training. One of the indicators that we have is how they are doing on the lower extremity muscle scale from the ASIA testing. So you can see in this example that I've given you, we're looking at the key muscles of the lower extremity on the right and left sides. We're totaling those and looking together at that total. In this example, the patient is 27, which means that they have good potential to be an ambulator. So that's just a helpful start. We'll look at some of the other information that we do have, although none of the markers that we have so far are excellent at clinical prediction. I also want to call your attention to this swing through gait pattern down at the bottom because it's just really important to think about how this looks very different in a patient with a spinal cord injury. The patient really has to rely heavily on their Y ligaments here just in standing with upper extremity support and just biomechanically stacking over top of the lower extremities. Likely this patient has KAFOs on at least. So, and then just thinking about the amount of muscle that it takes for them to hold up their whole body weight and move through to this mid position, and then the balance that it requires moving from that posterior position to the anterior position. The predictive value of the AIS grading is probably just in general one of the best things to look at. We can think about the fact that if somebody has an AIS grade of A, they have less, they are less likely to be ambulators as opposed to an AIS D grade, which I think makes a lot of sense for us. This clinical prediction rule that was brought forward in 2011 has been found by the Neuro Academy interest group to not be as sensitive and specific as we would like it to be. And so I've linked that for you should you have a particular interest in looking at that and a more recent study. But I think the important thing to take away from this is that we're trying to be more targeted at who would benefit from ambulation training. And I think this will be a patient by patient decision. especially at the thoracic level. As we move down into the lumbar levels and below, then those patients have a higher likelihood of using ambulation for full time, especially if they're incomplete injuries. So incomplete injuries make a whole lot of sense for us to work on ambulation because that can help to progress the muscle function as they're using that. Otherwise, for thoracic levels especially, that's going to be mostly for exercise purposes. Here are some locomotor training strategies that we're going to be using. Remember, similar to other things, we also have to be interested in the setup. So we have to teach them very carefully about putting on and removing their own orthoses. We're going to probably be integral in helping them decide the orthoses as well as the assistive devices, but we have to teach them how to be able to sit to stand with those devices. And then we're going to work very intentionally on standing balance and weight shifting. And then beginning to work into those push-ups to be able to have the muscular strength to manage those transition phases. Again, we're using either a swing through pattern as we just went over or a 4-point gait pattern. And then we also have the possibility of doing locomotor training with body weight support and using that either over a treadmill or over ground. I want you to go ahead and watch this video of a T7 spinal cord injury patient using the reciprocating gait orthosis, the RGO. We learned a little bit about in pediatrics, which then assists the stepping forward. You can see that this patient is using it for exercise purposes. When we are thinking about locomotor training, we're going to use that on the treadmill with that body weight support to provide really intensive practice. But that's not going to stand alone. We're going to use that in conjunction with training over ground, especially right afterwards if possible, so we can use some of those new skills. We're going to encourage reciprocal stepping, and hopefully then the over ground helps that patient to work on their balance during the propulsion. And we're really wanting the patient to train like they're going to walk. So whatever environmental conditions they're going to be doing that in, and we may have to take into account any behavioral considerations. Here's some nice pictures of this gentleman receiving partial weight-bearing treadmill training. You have a person on either side of the patient who is advancing the limbs. You usually have someone behind for safety and support and balance, even though you've got the harness. And so that's a really nice visual. You can see that it takes high manpower for that to happen. Some general guidelines that we usually look for when we're doing this kind of training are maintaining about 35% body weight support. Okay, so most of them have their own ability to record that built into the partial weight-bearing harness. We're looking to try to drive that central pattern generator, so we want the speed of the treadmill around 0.8 to 1.0 meters per second. 20 to 30 minutes at least of total stepping time, and you'll see when we get to some places they do as much as 60 minutes, I think. 3 to 5 days a week. And then they're going to add overground training beyond that. We're really trying to load the lower extremities as much as possible so that they don't have to use upper extremities. Okay? Some sensory cues that you're providing, each person on their own side, you're providing tapping or pressure over the extensors in stance phase and over the flexors in swing phase. So all of that should be timed, both the posture, the trunk, the limbs, kind of coordinated together. So that back person can be helping with trunk lateral weight shifts if need be, to also coordinate with the limbs. So right limb has to be coordinated with left limb, etc. So any compensatory strategies are tried to be eliminated by the people that are assisting. So this is very different than letting the patient do as much as they can. This is training and training and training near normal patterns. Okay, this is when we're really trying to get back to complete pre-injury patterns. This is a nice little video that I'd like you to stop and watch, done by the primary researcher here at Louisville, really focusing on the fact that spinal cord can really assist in regaining some of that functional control, especially with really high dose training. Okay, so go ahead and watch that. This is also another nice video that gives you a visual on some of that high intensity training up to 60 minutes, and then you can see the overground training that's done immediately following that. It also has a nice demonstration of standing balance activities and sitting balance and trunk strengthening. Especially what I like in this video is you can see how they put essentially bike wheels on the weight bars so that a patient with a spinal cord injury can exercise a little bit more independently. So it allows a sort of a natural spotter, because if they drop it, the bike wheels are going to protect them from the weight actually falling on them. So they can actually do bench press and supine independently, because it'll rest right above their body, and so they can be practicing with that in addition to some of the exercises that you see in this nice video. You know, a big take home here is that we need to push our patients as much as possible within safe parameters to reach whatever their maximum potential is. We're going to be there with them to keep them safe, so we'll be able to get that just right challenge when they have us with them, as well as set the just right challenge for what they can do by themselves safely. Another nice video that I'd like you to watch. Again, I love it when you all go ahead and watch and start laying your eyes on things to see how you think it's looking. So take a look at this and see if you would do anything differently, how you might change it, and maybe start thinking about what muscles this patient needs to strengthen. A spoiler alert, start thinking about what other activities you might be able to use, maybe some developmental positions that you might be able to use to strengthen those muscles out of task. So the other thing that we need to be a lot more intentional about with this patient population are wheelchair skills. People who are going to be reliant on wheelchairs for their mobility, possibly in the home or the community, especially if the manual chair. So we can determine there might be some patients that have the ability to use a manual chair in the community or a power chair. So I love this wheelchair skills checklist. You can kind of take a look because it makes us think about things that we don't automatically think about. And so go ahead and take time to read through this. These are going to be things that you're going to intentionally evaluate and then train if they aren't able to do them, right? Especially for this population, we're thinking of their ability to shift their weights and relieve pressure, and then go up inclines, go down inclines, and eventually there are some nice videos we'll talk about on the next slide about how to teach patients to go up and down curbs and do all the fun stuff that you all like to think about, like wheelies and descending a curb and descending inclines in a wheelie position. We're not going to do those ourselves, but if you go to this next one, this is a fantastic site here. If you click on either of these, it walks you exactly through and has a lot of nice videos on how you would teach some of these higher level skills that are really pretty impressive. For us, we're just going to be looking at and thinking about some of the basic skills. But again, you're going to see skills that are specific to, this one's for manual wheelchair users, but there's also one specific for training power chairs as well. Spend some time just looking on that. I think you'll find it really, really fascinating. So we're familiar with the FIM, the Functional Independence Measure, and the SCIM just has a lot better sensitivity and specificity for use with spinal cord injured populations. You can see here some things that we wouldn't necessarily see on the FIM, like respiration and sphincter management for both the bowel and the bladder, as well as their ability to prevent pressure sores, and other things which seem a little bit more straightforward: ADLs, feeding, bathing, transfers, and mobility skills, stair management, getting in and out of a car. One that we haven't really thought about, or we just looked at a video on, was the transfers from the ground to a wheelchair. So what I want you to understand is that there's a very specific FIM for spinal cord injured patients, and that 100 on that would be completely independent. Okay, so a higher number is more independence. We touched on this in lab just a little bit about the psychosocial considerations, thinking about this person from a loss of independence, a big change to their body image and their life roles, they may need to be thinking about equipment and long-term costs. The vans for especially a power wheelchair are not typically covered. So thinking about how the patient could meet some of those needs and thinking ahead for them is going to be important things to help them think through when they're ready for that. But we're also going to rely on some of our team members to help us through that. We know we've got to think about these issues, not that we're going to be the ones in charge of bowel and bladder or sexuality and helping the patient with that, but we can provide a lot of support by being aware that they're going to have to fit that in with their schedule, knowing when we might need to refer or advocate for a patient for those needs, thinking about their high risk of UTI, and then thinking about that catheter in the case of autonomic dysreflexia and checking that as one of our number one suspects. Okay. As far as sexuality goes, if you're in this patient population or working with them on the regular basis, you will probably get some education surrounding that, so you will be able to help patients through it. But you really want to, either by your verbal, what you say to them, or how you set up a safe space for discussion, letting them know that it's okay to ask you questions. Not that you might have all the answers, but you will probably know who to refer them to or help advocate so that they can find those answers, because that's a huge component of a personhood. And we're going to talk a whole lot more about that in the summer with the psychosocial aspects of rehabilitation that you have me for. Functional electric stim. They have used this pretty successfully with patients with spinal cord injuries so that they can get regular exercise. And I think they have found that while it doesn't necessarily promote recovery, it does allow the patient to get more improvements from a cardiovascular standpoint when exercising both the upper and the lower extremities. So you'll find that patients can get set up with a home setup, a functional electrical stim, and a bike. Also, which is really interesting, is the exoskeleton. This is a robotic orthosis that helps patients be able to walk. And we've got a nice video for you to watch about that. Keeping in mind that especially in the acute stage, you're going to have a full rehab team. And this team works closely together for this patient population. You're going to have neurologists, neurosurgeon, possibly orthopedic surgeons coming in and out, people that can manage pulmonary concerns. And then the physiatrist is sort of like the quarterback for the whole physician team. But you're also going to have PTs, OTs, case manager, recreational therapists. We got to see that hopefully in the first year and learn a little bit about that to help people get back to finding meaningful recreation and leisure activities. That you can see that the respiratory therapist would be important. We're going to be working closely with nursing, dietitian, possibly a rehab counselor, orthotists, social workers. You're going to have psychologists available. And we talked just a little bit about vocational rehab and letting the person know that there may be some avenues that will help them get back to some sort of meaningful paid employment, or at least some kind of meaningful volunteer work throughout the day. Okay, peer counselors are very important with this patient population, and a lot of times they'll run groups to help facilitate that on the rehab floor. Assistive technology is going to be a big part of most of our patients with spinal cord injuries, and the really cool thing that I got to see when I worked at Woodrow Wilson Rehab Center is that they also had rehab engineering. So if we got some off-the-shelf assistive technology that wasn't quite working exactly as we needed to for a patient, we could call in rehab engineering and they could adapt that equipment. This is a lovely little cheat sheet of how to think about some general goals and outcomes that we might want for our patients with different systems that we're going to be looking at in their functional mobility. So I'd like you to take some time and look at that and think about that. But what I've linked here for you at the end is a really nice PowerPoint that takes your table 20.5 from O'Sullivan that I've already been pulling out some information from and thinking about what at each level what comes along. Okay, so we've been typically thinking about what the available movements will be and what muscles will be there, but this also takes it through and helps you to think about by level what we anticipate their function to be for bed mobility, transfers, walking, driving. Will they need an attendant with them, either full or part-time? Will they be able to do their ADLs with somebody, or be able to, sometimes if it's dependent, we need to have them feel comfortable and confident instructing people what to do. So I've made a little cheat sheet here, and I'd like you to read through it and think pretty carefully. You should be able to think backwards a little bit. It should make sense from their available movements and what we've learned so far about how they move and their bed mobility and transfers. Should make sense, but it gets you to think on a deeper level about what this patient's life and what their chances of either walking or using a wheelchair, power versus manual, and will they need adaptive equipment. Okay, I'm not going to sit and go through all those. I'd like you to read through them because we'll be doing an activity in our cases where I'm expecting you to sort of work through that. Now, I'll also post the actual table because it does have a little bit more detail, so you'll have access to that as well. This is sort of more like a quick snapshot of each level. Okay.